Warning, all attendees are in listen-only mode.
Good afternoon. I'm Lorna Lucas, Assistant Director of Provider Education for the Association of Community Cancer Centers, and I'm eager to introduce Charles Lynch, our expert presenter for the 8th e-course in the series hosted by the Institute for Clinical Immuno-Oncology, or as we refer to it, ICLIO, who will discuss navigating patient assistance programs and access for immunotherapy treatment. As you may know, the ICLIO initiative focuses on preparing the multidisciplinary team for the challenges and opportunities presented by immunotherapy and includes other vital resources such as newsletters, papers, scholars program, and a national conference, which will be held this September 30th in Philadelphia. Please visit our website, www.accc-iclio.org, to browse all of our offerings. Now for today's e-course, I'm pleased to introduce Charles Lynch, who's the Program Coordinator of Oncology Medication Assistance Program at the Smilow Cancer Hospital at Yale New Haven. Mr. Lynch established the Oncology Medication Assistance Program at Smilow Cancer Center at Yale New Haven Hospital. The MAP program was created in response to increasing reimbursement issues causing delays in patient therapy and increased hospital write-offs. Mr. Lynch works to reduce the barriers that delay access to patient therapy. He also advocates on a national level with pharmaceutical companies in an effort to enrich patient and provider developments, as well as reductions in patient enrollment eligibility criteria. Mr. Lynch has also spoken at several national meetings specifically pertaining to reimbursement and concerns with patient assistance accessibilities. Now for a few housekeeping notes, please feel free to submit questions to our presenter by typing your questions in the box on your dashboard. We'll also be joined by Jennifer Hinkle, partner at the McGivney Global Advisors, who will pose questions to Mr. Lynch at the end of the presentation. This webinar will be archived and available on the ICLIO website. Now I'll send it over to Mr. Lynch to kick off the webinar.
Good morning, and thanks for having me. So today, basically, we want to talk about patient assistance, financial access, and we'll jump right in by first saying why and how patient assistance programs benefit patients. So if we go to our first slide, we could see that there's a variety of patient assistance programs and services available. Today I'll show some examples and case studies of IO patient assistance and ways to navigate through some of these challenging problems at times. We're also going to talk about managing and optimizing your internal procedures for best staffing for patient assistance programs in general. So if we can go to the next slide. So one of the important things is how and why patient assistance programs benefit patients and providers. And now, if you look at today's out-of-pocket expenses, which are huge and escalating at a rapid increase, you realize that patient assistance now is a major benefit for the provider, where before it was always looked upon that, okay, it was for the patient, it assisted the patient in obtaining whatever they needed to obtain, but it was never looked at as a way of preventing write-offs, which are now escalating at most hospitals and community centers due to the large amounts of patient out-of-pockets. So if we can go to the next slide, please. So patient assistance programs benefits for both patients and providers. So services ranging from copay cards to benefit investigations can help patients manage financial burden of out-of-pocket costs. Understanding their coverage and their benefits could help remove any hurdles to continue treatment. And we see this a lot where a patient doesn't know or even have an idea of what their out-of-pocket expenses are, and all of a sudden they're hit and they're brought into this world of oncology where they're thinking their deductible is similar to that of their auto insurance deductible, and all of a sudden they're hit with $5,000 to $8,000 deductibles and out-of-pocket expenses, in addition with copays. So being able to help a patient understand and also navigate these programs is very beneficial. Now for providers and provider groups, which are the practices, hospitals, using patient assistance programs can reduce financial liability of non-collected copays and co-insurances that can extend staff to and your staff should really understand how this benefits your hospital. At Yale, we now have a pilot in place where every patient, regardless of their drug in oncology and immune oncology, their benefits investigations get bounced to us, and we actually have somebody go through and review and look for any kinds of out-of-pocket expenses that the patient might have, of which we can put them in. So we always target the high-cost drugs first and work our way down there. And you'll see that we looked at last year's numbers, the amount of patients that were going into collections was just escalating at a rapid rate. And you have to sit back and say, well, why is this happening? Well, this is happening because patients now have out-of-pocket expenses at levels they've never had before. And the realistic view on this is, can a patient really afford to spend $8,000 to $10,000 out-of-pocket per year? And especially if they start their regimen, let's say October, November, December, and now in January they hit another deductible in another year, a patient can easily rack up $18,000 to $20,000 within 5 to 6 months. If you take into consideration that patients making $50,000 or $60,000, you're talking about a good third of their income going towards out-of-pocket expenses just for their treatments. So if we can go to the next slide. Okay, varieties of patient assistance programs and services available. So when we take a look at that, you'll see there's several different types and how to navigate through these. So next slide, please. So types of patient assistance programs. So many of our manufacturers will conduct benefit investigations for all patients. So one of the best practice models is if you don't have somebody doing benefit investigations at your practice, or even if you do and you're unsure, like with some of the new IO drugs that are coming out, and you're not sure whether there's coverage or not, and the problem being a lot of these don't need prior authorization, so the assumption is that they're just, oh, they're covered, and then you find out they're not covered. It's good to always throw these benefit investigations through the manufacturer's benefit investigation program. So that's one way of assisting and helping out and managing how you're going to get paid and what the patient's out-of-pocket expenses would be. Now, if we look at manufacturer assistance programs, many of these include copay discount cards, coupons, and vouchers. And again, one of the newer things, and it's really a great tool, are the starter packs, whereas the starter packs can actually start a patient on therapy, and some of them are good for 3 weeks to a month, where now if you have to go through the prior auth steps and you have to secure copay funding or whatever it might be, you can at least not delay therapy on your patient and you can jump right into it. So starter packs and these vouchers are really great. The next thing is these third-party programs, which include the copay assistance foundations. With these foundations, you have Patient Advocate Foundation, you have Patient Access Network. They're really good for your Medicare patients, which we'll talk about in a few minutes. And then many manufacturers also have programs for uninsured and uninsured patients, or patients rendered uninsured, which sometimes is due to off-label use, and they provide free or replacement drug for qualifying patients. Now, this is very important because you want your best chosen therapy for your patient, and if it happens to be an off-label indication, if you don't do drug replacement and obtain some free drug, well, then what are you going to do? You're basically going to write it off. So now you have this escalating write-off for this drug times the amount of patients that might be on this regimen. The numbers just keep adding up and adding up. So this is a good way to cost avoid not writing off any of these drugs. So a key takeaway is patient assistance programs go beyond copay cards and have many other additional services available. Next slide, please. Okay, so if we look at the types of programs and patient eligibility, you'll see there's traditional patient assistance programs, and within them you have copay cards, vouchers, and coupons. These are just for your commercially insured patients. Government-funded patients, which are your Medicare, Medicaid patients, are not eligible to use any of these coupons or copay assistance. And they're generally limited to the use of products that are FDA indicated. Now, there's independent copay foundations. We use these a lot, and these are for our Medicare and Medicaid patients that are not eligible but need some kind of assistance in obtaining their medication. Some of these challenges could be, in order to put a patient through one of these foundations, you have to go to the disease state of which the patient is being treated. So example, patient's a colon patient, you'd have to go through a colon fund, lung fund, lung patient, lung fund. So again, these funds, what happens is sometimes they rapidly get absorbed and there's no funding and you have to wait for them to be refunded. So that at times could be challenging, and that's when you bounce back and forth to different foundations hoping that their fund hasn't closed. And then there's manufacturer access foundations. So your manufacturers will provide drug if your patient is uninsured, underinsured, or again rendered uninsured, possibly off-label use or pharmacy benefit max outs, whatever the case might be. And these are generally limited to on-label use, but they are more flexible. With that, you have like your Bristol-Myers Foundation, your Genentech Access to Care Foundation. So next slide, please. So where can I direct patients? So this is something that can sometimes be a challenge, especially if you're starting off or you're not sure where a patient fits, or maybe sometimes your practice is comfortable using just copays. So you're just covering your commercial insured patients and you're really not doing anything for your Medicare patient. So it's important to kind of understand that you can navigate your patients through pretty much anything. You just have to know where to go. So this is a really good chart that a commercial insured patient could go through copay cards and traditional patient assistance programs. Your backups would be your manufacturer foundations in the event you couldn't use them. If we go to your Medicare or your Medicare patients without supplements, well then you'll have to go to your excuse me, independent copay foundations. That being, excuse me again, Patient Access Network, Patient Access Foundation, Leukemia Lymphoma Society, any of the foundations set up. And again, your backup is your manufacturer. So one of the important stresses to put in here is, let's say you have a Medicare patient that needs copay assistance for a particular drug. There's no more funding available. That patient can now be rendered uninsured because there's no funding. The manufacturer will then, once they know the foundation is closed, and provide free drug. We generally have no problem with this. Companies are really good about doing this. So again, they want access to be available for your patient. And then we have your uninsured and underinsured patients and patients that are, again, rendered uninsured due to coverage denial. Again, off-label use. So then you'd go to your manufacturer foundation. Very good about getting patients in there. The only thing I stress sometimes is if you're living in a high-cost area such as the Northeast or the Bay Area, that sometimes patients don't fit into that criteria, and that's where it can be challenging. So just because it's challenging does not mean it's the end of the story, and that's when it's really good to have field management representatives from the sponsored companies to come in, and you can kind of go over each case and come up with a solution. So next slide, please. Okay, so assessing copay foundation funds. So Medicare patients or Medicare patients have a copay and it exceeds what the manufacturer, like, let me look at this again. Okay, so Medicare patient has a copay and, okay, sorry. So basically your Medicare patient, again, they're excluded from using any manufacturer's card. So your patient can't pay for the drug. What are they going to do? You're going to go to a copay foundation. Your copay foundation, again, like I said, we're going to go to the disease fund. We're going to find where we can put that patient. Again, if it's an oral patient and I put a patient into a program using one of the foundations, you can actually instantly get approval and your patient can pretty much walk out the pharmacy right then and there, providing the medications available. If it's a specialty pharmacy and it has to be mailed, they could FedEx it out the next day. But again, whenever you're using foundation funding, you can get instant approval. There's actually no delay in getting the medication for your patient, which is great. Now for IV use, and I kind of like to stress the fact that when people think of copay, a lot of times they think, well, copays for my oral drugs. Well, no, copays are definitely on your IV drugs, and that's how hospitals recover a lot of money now, by using these sponsored copay assistance programs that pay for IV drugs. So again, the same thing, when you're using foundation funding, you can get instant approval for your IV drugs. The only thing are those claims will then have to be filed by fax mail or with an EOB. And again, so you have to wait until it actually bills out, the patient gets the EOB, and you could submit that. Here at Yale, we're very unique in the fact that we've figured out a way to pull out of Epic a patient EOB once the payment's been paid, so we don't have to go to the patient and ask them to bring in their EOB. So we've kind of streamlined that process, which is really great. And we're happy to share that with anybody who has Epic or needs to figure out how to extrapolate an EOB to where you don't have to burden the patient anymore, and it really cuts down on time. And then you're able to process your payments quicker. Again, your payments coming from foundations can be either in the form of checks or virtual credit cards or ACH transfers, which are new, and we're trying to get done here right now in Yale to use the ACH transfers. Just have to go through a couple steps to do that. But again, this is a great option to use for your Medicare patient. Your Medicare patient who is either on an IV drug or a PO drug who doesn't have a supplement, definitely go to your foundations. And just to kind of jump in there and say, you know, when we look at foundations, the purpose of these foundations and these funds to stay funded is if a pharmacy dispenses a drug properly, we're not going to deplete these funds so quickly. And what we've seen a lot, and you know, even in some specialty pharmacies, there are a lot of oral chemo drugs that can still be dispensed under Medicare Part B. Whereas if the patient has a supplement, there's a zero copay. Those drugs being like the Cytoxans, methotrexate, etoposide, etc. There's a long list of them. So also knowing that if a pharmacy is billing a drug right under Part B, as in boy, instead of Part D, as in dog, you're going to save a fund from being depleted when you really didn't have to go to foundation funding, where it was something that was covered at 100%. So again, using a specialty pharmacy or pharmacy that really knows how to bill a patient correctly is key, because we still see this a lot, and we see it in a lot of bigger pharmacies. So next slide, please. Okay, so case studies and examples of using patient assistance programs for eligible patients. And if we go to the next slide, I can tell you that these case studies are real case studies. They're from patients. And we'll just kind of tell you how we can navigate through these. And the first patient is 62 years old, so I'd like to say, first of all, that this patient's a commercial insured patient. Patient's going to be treated off-label, so this patient's a 62-year-old woman who's commercially insured. She's being treated with a combination therapy of Exempra and Avastin for ovarian cancer. Her insurer has denied the request and has determined that the combination regimen is considered experimental and deemed not medically necessary. Now, with this combination, which we use a lot here, sometimes one drug is covered and the other one's not. It depends on the payer. It depends if it's some deem it combination therapy. So it's all over the place. But for this particular patient, both drugs with their insurer were deemed off-label, and we couldn't get the drug for the patient through her insurance. So what we did was we enrolled the patient. So we went to the patient assistance programs for BMS, Bristol Myers Squibb, their access support, and Genentech access solutions. They did a benefit investigation, came back and saw that the payer was not going to pay. So what they did was, you know, they both rendered the patient uninsured, and they then triaged it to their foundations. From there, the end result with this particular case was the patient met the financial criteria. She was approved for both patient assistance programs, so she received both the Exempra and the Avastin. The clinic then receives up to 12 months free drug for each date of service replacement drug. And what this had done was this had enabled our patient to, one, get treated with the best therapy that the physician wanted to use. Two, not only did we treat the patient, but we didn't have a financial write-off. And three, the patient did not have to worry about being a self-paid patient, of which most patients on this regimen couldn't afford to be a self-pay patient anyway. So when you look at this, what did this patient assistance program do? It created a win-win effect for both the hospital and for the patient. You know, again, best practice would be patient got treated with best therapy. Next slide. So our case study number 2, what we're doing is we're using copay for an infused drug. So in this particular patient, this was a 56-year-old male. This patient was being treated for non-small cell lung cancer. The patient was commercially insured. The patient's being treated with Keytruda. The patient has an out-of-pocket expense of $1,290 for the first 3 injections. So $1,290, so that's $1,300. That's 1, 2, 3. That's $4,000 out of pocket. You know, not something somebody generally keeps hanging around in their rainy day fund. So the patient, we informed the patient that he could go through Merck Access program. So we enrolled the patient. And what I'd like to say is, what we do is we enroll all our patients into all these programs. And some of the movement on some of these companies are now shifting towards the patient have to enroll in themselves, which is, you know, we continue to advocate that a patient it's not a best practice for a patient to enroll themselves because, one, they can't manage sometimes the EOBs. Two, it puts the payment process on them. They have to send in the EOBs. They therefore then get the check. They have to remember to bring the check in. And they're being treated for cancer. They don't have time to, they have other worries in their life. The last thing they want to do is have to worry about one additional financial step. So the fact that we can enroll patients, take the burden off of them, and then manage it internally is a great practice model. Again, any companies that are doing this shift towards shifting it on the patient is really doing a disjustice for the patient. So getting back to this patient, we could look that this patient now pays through the Merck Access Program. The patient is paying $50 out of pocket for his infusion, and the remaining balance up to $25,000 per calendar year would be covered. So in this particular patient, he's only going to use like $4,000 worth of copay assistance, but that's $4,000 not out of his pocket. Merck was very generous where they would have given $25,000, but by then this patient, after 3 treatments, reached his out-of-pocket expense and didn't need any further assistance. So again, this shows a great program, helped the patient. Patient paid $50 per injection as opposed to $1,290, saving the patient $1,240 per injection. Next slide, please. So as we go into the case study 3, the case study 3 is a commercially insured patient who is being treated off-label. So this patient, I'm sorry, it wasn't off-label. So this patient is a 66-year-old renal patient. The patient has Medicare A and B. The patient does not have a supplement, and the patient is being treated with the Opdivo. So Opdivo is the new drug we're using. We're using it a lot at the hospital. Again, Medicare patients, a lot of them have A and B, but they don't have a supplement. So this patient had an out-of-pocket expense of $1,170. So with that being said, again, the patient's a Medicare patient. The patient needs foundation funding because he cannot use any copay cards through the company. So what the patient does is the patient now has to be put into a foundation. So with this particular patient, we went to Patient Advocate Foundation. We secured the funds for the patient. The patient is now being treated. The patient doesn't have to worry about any out-of-pocket expense. An important factor to remember is, one, the patient's treated with the best drug you want to do. 2, there's no liability for the patient. 3, there's no write-off liability for the hospital, which will become a potential write-off. And then when you look at this, what you have to understand is, okay, so a patient has an out-of-pocket. He doesn't have a Medicare Part B supplement. So what we're going to do is we're going to kind of recommend to the patient that it's going to be good to get a supplement. You're going to be treated for a while. Why not get that supplement? So you have to remember that if he has this, if he's going to have $1,170 each time he comes in, eventually that copay grant's going to run out because it's not that big. So we're going to have to either seek funds somewhere else or hope that he's in a new enrollment period where we could get him a supplement and we don't have to worry about the patient therefore running out of funds. Again, though, these foundations are great because they're a godsend for these patients that could not afford to spend this amount each time and for each treatment. So again, it's a win-win situation. When you look at it, a lot of these reports being done, I believe it was Genentech did a trend in their oncology trend report, they said that only 27% of all copays of everybody they surveyed were actually being paid, which means there was a remaining like 73% of copays not being collected. So when you copays and out-of-pocket expenses, so when you look at these copays and out-of-pocket expenses not being paid that are just going to start accumulating, this was something we never dealt with 3 or 4 years ago. You had patients that had out-of-pocket expenses, but you never had a whole population that had out-of-pocket expenses to the extent of today. So again, all these fees that you're not going to collect more than likely are going to be write-offs. And how long can you sustain yourself writing off these fees? It's not going to be very long before you realize you're going to have to do something. So the best approach would be to either start or enhance your patient assistance program. So next slide. So managing and optimizing your internal procedures and staff, and what you want to do is put together the best patient assistance program you could do and make sure you're utilizing it in the best way you can do it. So next slide. So basically you have to ask yourself, do you know if your practice or hospital is optimizing patient assistance programs? Now, if you are you utilizing them to the fullest? Are you using benefit investigations? Are you managing the amount of patients coming in that really truly can have help? At one time, we were probably capturing I'd say 10 to 20% of our patients. As of this year, our goal is to capture every patient that walks in the door. So we're going for that 95 to 100% goal rate. Again, you have to identify a patient, which has always been one of the toughest things. You have to have that point person. Who's going to be the one who's going to identify this patient, and how are you going to go through it? Who's going to understand and go through the various manufacturer programs, understand copay foundations, understand the patient assistance programs to optimize your reimbursement? And do you have enough financial counselors or staffers to access something like this? Many practices feel that the financial counselors pay for themselves after a period of time. So they start off with 1, 2, 3, and all of a sudden they're like, wow, this program's really, we're optimizing the amount of money we can have coming in. We have our patients that are satisfied because they don't have all these out-of-pockets that are not being covered, and yet we're collecting our copays. So again, that win-win approach is what you're looking for. Next slide. So building and staffing a formal program. So having a formal program is important, because if you don't have a formal program in place, you're not going to capture as many patients as really need to be captured. You're going to just have that, what I call, trickle-down effect. You're going to hear somebody say patient so-and-so needs help. A nurse might call you, or a social worker, but you really kind of have to have a formalized program in place to where you know exactly what patient is coming in on what day and what their out-of-pocket expense is going to be and what kind of assistance they may need, whether it's for an oral oncolytic or whether it's for an IV drug. So your program can start off small and grow as financial benefits are recognized, and it really doesn't take long at all before you realize that your the benefits just outweigh whatever you might think FTE would cost you, or a couple FTEs. So again, your best practice would be to collaborate with internal departments, which we do here at Yale. We talk to pretty much every department. If somebody does fall through the cracks, we know about it, but we now have a process in place where there should be no one falling between the cracks. The only time somebody should at this point would be somebody who we find changes insurances and nobody was notified, and nobody took their new insurance card or ran a benefit investigation, and they were riding on the old benefit investigation. So again, getting somebody in there who knows, starting a formalized program, running a benefits investigation, and having a real ownership as to who's going to take on this challenge. The environment's changing, more patients are experiencing high out-of-pocket expenses. And I say this, I keep saying this because it's taken different practices quite a long time to realize that what they used to be able to see as out-of-pockets and write-offs were just a small percentage of the population. Now you're seeing it straight across the board. You're seeing a greater, vast amount of patients coming in who have no way of understanding how they're going to pay for anything. And again, if you're a smaller practice, you cannot afford to continue to write these off. So again, putting a formalized program in place would be your best practice. The potential write-offs, just keep escalating. That can be eliminated. You can bring those numbers down. You can bring a lot of cost value back into your hospital. We say that in a climate like today, we're looking at lower reimbursements. We're looking at greater acquisition costs, and a patient assistance program could actually add value to your program. Very important to do. We've done it here. Our numbers are great, and we keep setting goals each year and keep achieving those goals and actually exceeding them. So this is an important thing to integrate. You need this successful program to assure that both the patients and the providers would benefit. You want to maximize your patient financial liability being taken off of them, and again, bringing in the dollars to your establishment. And you want to have your patients always get the best preferred course of therapy. So in saying that too, I think a lot of times when treatment plans are looked at, in some practices, when you look at a treatment plan that might be generic, it's not the preferred one, but you think it's going to be cheaper in the long run. Well, if you integrate copay cards, copay assistance to a brand name product, your patient is actually better off than if you use the generic drug, of which there's no copay assistance, and their out-of-pockets will be their true out-of-pockets of what they're going to have to spend. It might be true they're not going to achieve their out-of-pockets as quick on a generic as they would a brand, but at least that brand drug has a backup to kind of cost share for the patient. So again, look at the therapy you really want first, and realize that if it is brand, there's usually always some type of assistance associated with that brand name drug. And next slide. Okay, so resources. Resources are always important in oncology. There's so many different places to go. One of the good resources right here is the ACC CE's 2016 Patient Assistance Reimbursement Guide. If you go to it, it'll list different drugs, different ways to access patient assistance. And saying so, I'd like to say when you look at patient assistance and you look at foundations, some of the foundations, like Patient Advocate Foundation, they're more than just a copay foundation. They have case managers available. So if you need a little bit more, you could kind of refer a patient to that. I had a patient a couple weeks ago, and well, actually it was probably more like 2 months ago, but they were looking at a new Medicare policy. They didn't know what to do. I sent them to Patient Advocate Foundation. They got a case manager to kind of walk them through what meds they were on, what they were doing, where they needed to go, and what was recommended. So when they went and they talked to a salesperson, they knew what supplemental program to buy. They knew the best case for their disease state. And I think sometimes when you use some of these advocacy foundations and they have a case manager or an advocate, they go just beyond, like I said at the very beginning, patient assistance programs is so much more than just a copay card. So utilize these programs, utilize these foundations. They're very essential in what you do, and also the relationships you build in doing this. If you're starting a program or you have a program, are you seeing your field reimbursement managers enough? Are you bringing in people, sales teams that can actually help you and kind of navigate? If you're brand new to this or you want to know how to start this, they're the best source. They're really great at connecting people and connecting different hospitals, different community centers to kind of talk and collaborate with each other. And we do an awful lot of collaboration here at Yale, where we'll talk to other centers throughout the United States, and we'll tell them our best practices, and they'll tell us theirs, and we kind of come up with what we work, and they take good from us, and we take good from them. So again, it would be to collaborate. Industry sometimes gets a bad rap, but industry provides a lot of assistance. So I guess you just need to kind of seek that out and look at that. So again, some of the resources here on this slide, these are valuable resources. It's a good place to start. It's a good place to gain additional information. And we can go on to the next slide. Okay, and here's an app. So now everybody who's up to date with apps, this is a great app. When your patient needs financial assistance now, it says it's just one click away. Everybody's using apps right now. I think this is a great avenue to explore. Maybe everybody could look at it later on. And next slide. Okay, so questions?
Hi, everyone. Charles, thank you so much. This is Jennifer Hinkle, and we do have a couple questions. So my first question for you, Charles, do you have experience with any payers responding negatively to copay cards or creating any hurdles to their use where you haven't been able to use them like you want to?
Well, actually we have, and this has been like something new coming about. It's been with one of the larger, bigger specialty pharmacies, where what they wanted to do was they wanted to only use swipe cards, the swipe MasterCards or virtual cards, to bill out on. They did not want to use a traditional copay card. They did not want to bill it out as a secondary. So we've had some challenges with that. That's something we're going to work further and talk to some legislators to see if possibly insurance companies cannot always mandate where the drug has to go in cases like this, because again, they weren't going to process the copay cards, and it took several calls and worked around it. And 2 of the patients, we were able to get their insurance companies to override and move move out of their system. But yes, so that's something where we've been seeing recently, and it's actually one of the bigger specialty pharmacies.
Charles, thanks. There's another question about off-label use and what might be the options for patients who have an off-label use, but the off-label use might be supported by compendia or NCCN or articles. Can those patients get access to any of these services?
Okay, so that's a really good question, and the answer to that is yes, most of the time they can. Again, working with the big companies, they're fairly good at that. If it's NCCN, then it's no problem. If there's any kind of supportive documents, it's generally not a problem. The problem you run into is occasionally you'll find something that's a little obscure, off-label, and you'll really have to search and go on the web and find something to back it up. And we've had some times where we've been able to find something used in either Europe or Asia where we have found printed information, and yes, it wasn't very extensive, and we've gone with that. We've had some challenges along the way, but generally the bigger companies are pretty good with that. We're a big teaching hospital. They know there's a lot of studies underway. Sometimes we'll say, hey, but it's in a phase 1 study somewhere, and this could be compassionate use. You're throwing it in a study. Obviously, there's some data that might not be published, but yes, there's possibly some clinical effect that this drug could be used. And again, we have pretty good luck with that. We've had a couple interesting things come along the lines at times before, but generally, I'd like to say the big companies are really good about that.
Okay, thank you. One other question that's come through, and this is about the Medicare patients without supplemental insurance. So in general, how much support can you expect for that category of patients? And this person wants to know, what can they advise to those patients who don't have supplemental and might not be eligible for manufacturer copay cards?
Okay, so basically, a Medicare patient without a supplement who's going to have a copay of which they cannot afford, what we would do is we'd definitely reach out to a foundation. And what you would do is you would then gather their information, enroll them as long as they fit into the financial criteria, and you could secure copay funding right then and there. Again, these foundations now do instant approval. Your patient can then access the funds, and I think sometimes the foundations are not even thought of as something that oh, we can go to a foundation, because older days they were a little bit more complex to run through. The processing of claims took longer. If you didn't fill it out and you surpassed your date, it turned into a big mess. So they're easier to manage now. So much is done online. Again, so you have a patient come through the doors, there's no supplement, they need something, go to the foundations. As long as those funds are open and the patient fits the financial criteria, which a lot of your Medicare patients do, then you have absolutely no problem and no reason not to access these funds. Again, the only thing is I would then see if possibly there's some way you could then steer the patient towards a possible supplement for the next enrollment year, knowing that most patients are going to continue on their journey for a while, and it would be best for them all the way around if they were able to have a supplement which would cover this. But again, remember, foundations are not what they used to be. They're so much easier to navigate. They're so much easier to use. They offer so many more resources. And if you're not sure, I always say pick up the phone. There's still live people when you pick up the phone. If you can't find anything on the net, doesn't always mean it doesn't exist. Call somebody, reach out to a live person, talk to them, and they'll walk you through. And these foundations are really good at that. They'll walk you through whatever steps you need in securing those funds.
Okay, thanks. Charles, we do have a number of additional questions that came in, and some of these are geared more towards technical questions in ways that you run your program. So
sure.
One person asks, are you enrolling the patients into the copay assistance program prior to their consent, or are you automatically enrolling them, enrolling those who are getting the eligible drugs and then getting the consent or having the discussion with them at a later date? So they say that they're running into a challenge staying on top of getting the patient's consent and getting them enrolled prior to the first treatment.
Right. Okay. So that could be a challenge. So if it's, again, if it's an IV drug, all these companies have a look-back period. So if, well, first of all, let me go back to our first step. Yes, we get the consent ahead of time. We don't do anything without a patient's consent. Some patients, you know, you do reach the occasional patient that doesn't want any assistance because they think there's some kind of stigma attached to it. And, you know, those patients generally, you could talk them down off that pedestal pretty quick and say, look, it's not charity, it's something you're going to need, everybody utilizes this. But so with that being said, you should always have and you should always get consent first. So is it challenging? Yes, it's very challenging because a lot of times treatments start before you actually get to the patient. So in order to kind of prevent that from happening, you know, I say there's very few patients nowadays that come see a physician in clinic and get treated 20 minutes later. So I always say you kind of really knew about it, or somebody knew about it before the patient came in the door, that they were getting treated for a particular drug. So first step is identify why you weren't notified in the first place, or, you know, identify a maybe best practice workflow that would help you identify that patient right off the bat. Secondly, if you can't do that, or you're not able to do that, remember there is a look-back period. So let's say a patient comes in my door today and starts a regimen. I'll just go back to that Avastin patient. Started Avastin. I needed to get this drug copay assistance or get it off label. There's always a look back. Look backs can be anywhere from 30 days to 180 days. So in that way, there's really no challenge in getting the drug either replaced or getting copay assistance replaced. Generally, you're going to know about it within that 30-day look-back period.
Okay, thank you. So our next question, how does the institution handle the infusion administration charges when the drug is being provided or paid for by a program? Do you write those off?
No, actually they should be paid. We have no problem. So what we do is we let it bill out. The infusion fees always get paid, for us at least, through our payers, and then we go in and we actually remove the drug charge, which is denied anyway. But no, the infusion fee is something that has to be paid even though the drug is free.
Okay. Another question, what do you do when the starter kits are branded?
Okay. Big debate always going on about branded starter kits and non-branded starter kits. So with that being said, we have a policy. We don't use anything branded here. I always say if it's not branded, you usually don't know what it is. So that's really hard. But with the starter kits, I mean, a lot of times you could remove any of the branded material on it. You could throw a card, your business card, over the branded part. You could somehow block out the branded, but a lot of companies will have unbranded material that you can take. And I don't know, I see a more movement towards hospitals, facilities having resource rooms which will take branded material. So there's kind of been a little bit of a movement more towards that. Again, all those materials are such a valued asset in any office or any environment, and because they're branded, they're not deemed being able to be used in a lot of institutions, but yet the institution wants the product to be used and the product services with that to be used. So it's kind of like a catch-22. So again, like I said, block out anything that's branded if you have to do that. If you have a resource room where you can use any type of material, bring that in there. I hope that gave a little clarity to that ever going on problem of branded and unbranded.
So another question, do you have a tracking method and a standard work procedure available that you use at your facility?
Yes, we do. And we find, you know, it took a while to really get a practice flow that really worked for our facility. We're a huge facility. We've acquired many community practice centers, and we had to find a way to integrate all of these into our system. So with doing that, our best practice that we do, and First of all, like I said, a patient generally doesn't get treated in the chair. I mean, there are occasional patients that come in, see a physician, and then an hour later get treated. But generally, because they're lab dependent, et cetera, you know about this ahead of time. So what we have here is a patient would go and see a physician. They'd walk out the door and have a scheduled appointment. The computer, we would then have an in-basket where the orders get sent to our patient account representatives. Our patient account representatives would do a benefit investigation, and then they send us a spreadsheet on a weekly basis, what patients are coming in, what their out-of-pocket expenses would be, and what drugs they're on. So I could look at patient Lynch, for instance, which is my last name, just so nobody thinks I'm saying a real patient. I'd look at patient Lynch. I'd say, okay, he's on cisplatin. Nope, there's no copay assistance for that. He's on Avastin. Yes, there's a copay assistance program for that. And we would actually go line by line and figure out who we're going to put into our program. We then contact the patient, let them know, hey, there's a program available which can reduce your copays and your out-of-pocket expenses. Do you mind if we enroll you in these programs? Can we obtain your signature while you're here in clinic? No problem. We meet with the patient. We have all the paperwork ready. The way we get the paperwork is, yes, we use a software. There's several types of software out there that facilities can use. There's a slew of them. There's MedData. There's Needy Meds. Actually has a hospital-based software, which we use only because it's a very, very user-friendly software. And it actually prints, you put in the patient's demographics, it prints out the application. We can then either email for a physician's signature, meet the physician in clinic, meet the patient, get the signatures, and we fax it in. But the software has tracking where you could track drugs as drug comes in. You'd track the drug, you'd credit the patient's account. You could take this and you could break it down by drug if you want to know how much drug you recovered. There's so many different features within that software, but it's a great tool because you can produce monthly reports on what you've recovered and what you've actually secured in copay assistance. So yes, so there is a software program, and again, the best thing you could do is find whatever workflow works for an institution of your size. Find the person or the personnel to do this. Again, it could be social workers. If you don't have anyone, it could be the pharmacy. It could be whoever takes ownership. And then go on and find one of these software programs, obtain them, and then build your program. And it's a short period of time before the benefits the financial benefits are seen. Again, I talk about financial benefits, but there's also the benefit of the patient, which is our number one priority, being treated with the best desired drug without, obtaining so much financial toxicity. And in talking in that, again, you have to remember that just your copays are just such a small part of a cancer diagnosis. You have transportation costs, you have days of work missed, et cetera, it just goes on and on. So actually, we kind of touch upon this. Me and one of my colleagues, we wrote an article for the American Journal of Managed Care, which comes out next month, an oncology evidence-based issue, and we kind of talk about different challenges that you can go through, and it's an interesting article. I feel we kind of touched upon some of the problems within the industry, some of the solutions, and looking forward, and how you can kind of achieve building your own program, and some of the reasons as to why. So it was a great compliment to tie into this presentation. Lost audio.
Hi, Jennifer. We cannot hear you, so maybe try muting. All right, I think we might have lost Jennifer to some technical issues, but we do have.
Yeah, I just managed to reconnect, and I do have a couple more questions that have come in if you'd like me to ask them.
Sure.
Okay, so someone asks, Charles, if you have any experience with these sort of programs ex-US, outside of the United States.
No, we tried assisting a patient with a program in another country, and actually Canada, and we had no success. So that I'll say no. We do have a lot of patients come in from other countries that get treated here. We're able to put, as long as they're residing in the States, we're able to put them in programs. I've had one company that was actually based out of Israel, a drug company that gave us drug for a patient here in the United States. So there are some unique things you could do, but as far as working with other programs outside of the United States, no.
Thanks. So someone asks, how do you find and print off the EOB out of Epic?
Okay, so with that, we actually have a step with that. I would have to look at I have a cheat sheet, so I could pull that out of my computer for a minute. But basically, I would say probably if anyone wants to email me, I'll give you my email address right now. Email me and I'll send you the actual directions to that. So it would be Charles, C-H-A-R-L-E-S, .Lynch, L-Y-N-C-H, and that would be at YNHH, so Yale New Haven Hospital, YNHH.org, O-R-G. And we have a whole step. I'm printing it right now, and I could go over it really quickly. It's very brief, but it's great because, again, like I said, a big challenge with the programs, and these EOBs that are out of Epic are accepted by all the major companies now. And what it does is it really just it takes the burden off of patients having to bring in EOBs. And then the other thing is there are times when you have a patient who, oh yeah, I'm going to bring you in my EOBs. They forget 3 or 4 times. They're bringing in 4 months of EOBs. The patient expires, and you cannot get the EOBs at that point, so what are you going to do? So this is really a great thing that we do. We go in and we get the EOBs. So basically, we use Epic 2014. So we'd sign into Epic. On the home screen, you'd click your tab, the Epic tab, and then there's a drop-down that's on your left-hand side. So you'd go into hospital billing, and then you'd hover over the click account maintenance, and a window would pop up. And within that window, it says account. So you'd place the patient's specific account number or correspondence. And then from there, you'd be able to go into the patient or the account, like I said. You'd go into the account summary tab, and that would expand at a point which shows a brief overview of the account. You'd select the date of service, where the account was, a treatment date. You'd then select the tab, treatment inquiry. Then you'd find payments and refunds, which is a section on the screen. So you'd go right into that. You would then click on the actual date of service. So anyone who goes in there, you'll see the dates of service, and you'll see under the date of service is actually like a little blue line. If you click on that line, it'll actually open up and show the payer's amount that was received and posted. And within that, you can click on that detail, and it will show the exact transaction detail, which is the EOB, which will show, the patient's out-of-pocket expenses, what they paid, what was the contractual write-off. It's perfect. It's the perfect EOB, and it's broken. Not only is it broken down, but it's J-coded out. So there's absolutely no reason any of the big companies wouldn't accept them, and they do. They accept them in lieu of the patient's EOBs. Again, if you emailed me, anyone wanted to email me, they could do this. And this was actually discovered and found out by one of my colleagues, Jacqueline Caban, and she actually was the one who printed out this form. And like I said, it's a great way to use an EOB and kind of take that burden off the patient. And like I said, it's one-stop shopping. You see the patient, you enroll them in the copay assistance, and now you really don't need to stop by and see that patient and track all these EOBs. Put it in your Outlook calendar, the treatment dates, and then you would just go back and you would just say, okay, 21 days after billing or 30 days after billing, whatever your system would be, you can go in and take out these EOBs and submit them. And like I said, you're paid relatively quick, 24 to 48 hours in most cases by most of these companies.
Thanks, Charles. And we have 4 more questions, so I know we're coming down to the end of the hour, but I hope that people might be able to stick around because we do have a couple of questions. Thanks, everyone, for your engagement on this topic. It seems like a hot topic. So the next question is whether you've had any challenges when you have another claim that gets processed prior to the drug claim being processed. So in that case, the patient's out-of-pocket expense hits or gets absorbed on the first claim, and then by the time the drug claim is processed, there isn't any out-of-pocket expense applied to that, but it would have been eligible for assistance had it been run the other way. So have you had that happen, and how do you handle that?
Right, it has happened before. There's not much you could do when that does happen. You kind of almost wish that the therapy was planned before whatever the other out-of-pocket expenses were that reached that point. Like I said, it's happened a couple times, but not a lot. We have done Neulasta. Well, actually, if you use like Neulasta, that's given after treatment. You're able to actually, they'll go and they'll help with the deductible that was covered on something else. So I shouldn't really say it like that. I'm probably not explaining it correctly. But yeah, but that's a challenge. We don't see it a lot, but we do see it. I mean, again, it depends. You know, if a patient's an ongoing rolling over patient, so a patient that we're treating and we've been treating that patient every year, more than likely they have a treatment date, you know, coming up in the beginning of the year, and that's not a problem. The problem is if it's a newly diagnosed patient, the patient comes in January with stomach problems, the patient goes through a CAT scan, and they want a PET scan, and they want additional labs, and before you know, at the time you come to treatment, they've already exceeded their out-of-pocket expenses. So, it can be a challenge. We don't see it a lot, but we see it on newly diagnosed patients that are new into the system.
Thanks. So another question is about using outside companies. So what about using an outside company such as Pharmatech to handle copay assistance programs for oncology centers? And this person asks if you would recommend internal dedicated staff versus using an outside vendor such as Pharmatech.
Okay, I would always say that internally, the best thing about an internal program is you know your patients, you have access to your information, and you're not a third party sometimes trying to remotely manage patient assistance programs. You have a vested interest in it, you're there, you're the face of the company. Your physicians know, you know, remember, there's a lot of times you'll see a physician in the hallway and they'll say, oh, you know, hey, Charles, we want to start a patient on XYZ. Is that a possibility? You don't get that service when you're on the outside. We found that when we looked at companies that do that, a lot of times they're more, first of all, you're paying a fee, and that fee could surely pay for an employee internally. It's more black and white when you do it. You know, I have, when any of our staff looks at anything, they have the whole EMR in front of them. They know exactly what the patient's on. We go in and we read clinical notes all the time, so I know that a patient's regimen might be changing. So therefore, what can I do? I can go and enroll a patient before we're even going to start a therapy. Remember how a few minutes ago we talked about what do you do when patients are already sitting in the seat and they've already got treatments and you haven't enrolled them in a program? That doesn't happen when you have boots on the ground in the establishment. You see what's going on. You kind of, and then you get a trend towards your patients. What's going to go on? It's easier to manage your patients when you're here. It's easier to manage when you're internally part of a team. Again, we collaborate with social work. We collaborate with the physicians and nurses, the prescribers. There's a whole array of patient providers that we deal with, and care coordinators, and just having that connection is something I think that being done by a third party on the outside, there's not that vested interest as much. I mean, remember, they're a business just like we're a business, but we're an internal business. I'll always say that nobody can take care of your patients better than you could take care of your patients. Once you start sourcing out your patients to anybody, are they really in good hands? Ask yourself, would you want your mother to be cared for by someone within the facility or a third party outside of the facility that might come in? And I'm not familiar if Pharmatech comes in or out. A lot of these, they do it all web-based, and they don't have this hands-on. Some of them do come in and have hands-on. Again, though, I'd rather have somebody part of our team. I think our management styles and skills are that of the hospitals or the establishment you're working in. Again, it's a third-party contractor. Do I really want a contractor when we can do it ourselves? And the cost value, I can tell you from my standpoint of view, there's no cost value in having someone on the outside do it, because the amount of money you could potentially save from write-offs and the amount of care that individual care you can give to your patient, that's something that you want to do. It's part of who you are.
Thank you. And then two other questions. The first one is that on new drugs, and the example this person gave was a specific case with Opdivo. The payer takes over 6 months to pay typically, and PAF will close their grant if no claim is received within 120 days. So have you had any cases like that, and how do you address it with PAF, Patient Assistance Foundation?
Okay, so if they close a fund and we didn't find out already, if you walk through there, they should. I mean, I asked to speak to somebody else at PAF, because I'm sure, first of all, they're always very accommodating. They understand things like that happen with new drugs, especially these, like I said, with Opdivo. When it came out, insurance companies were not requiring prior auths, and the assumption is it was covered, and then we're finding out it's not covered, and then you get these bills, and you have these co-pays associated with the bills. I mean, they're really good, but then they'll work with you if you kind of tell them. If they're not working with you, speak to somebody higher up in the company. Like I said, we work an awful lot with PAF, and they're extremely accommodating, especially if they know the situation. The situation is that you didn't receive something. We've always had companies that when there's been a challenge with look-back periods, you bring in a field reimbursement. So if it's BMS, call in their field reimbursement manager, tell them what the problem is, see if they can find a solution. Again, they're an asset too, even though they're not PAF. They do have some kind of internal way of figuring out what your next step should be. And like I said, we've had complex cases that just, some of them are like really storybook complex cases, and we've always had either a field reimbursement manager or someone from one of the foundations. If you go further up the chain, if you need to, always be able to assist us. And I think perseverance is number one. You just, if it's been 6 months before you were paid for the claim, surely you have 6 more months to work out this problem. It doesn't have to be done tomorrow. So I mean, relax, think of a proper way to get it done, but it does get done. And we've had cases go on for like a year and a half where, if you were going to write off these cases anyway, then take that extra month or 2 months to work through the solution and the problem. And there will be a solution. Like I said, it's not always the easiest, but we've always got paid when we needed to get paid, when it wasn't something deemed our fault, that the lack of, hey, this is a payer's problem. Because I can tell you right off the bat, PAF is so patient focused, they don't want the patient to suffer because a payer didn't pay, or send out an EOB or whatever the case might be on time.
Okay, thank you. So one more question, and this is our last question that's come through. Is the Needy Meds program you use, does that track co-pays, foundations, and drug replacement? So the person wanted to know if that encompasses all the areas of patient assistance.
Yes, it does. It does, and it's we've piloted a couple different ones, programs, the medication assistance program. Software that was out there, and like I said, we found that it was the most user-friendly. Again, you subscribe to these. It does both copay, it does both replacement drug. It's a good way of tracking everything. I use it to pull up monthly reports of what we received, because you can go into the patient profile and you could, you could then just add each time you get a shipment, you could add that in there and you could track everything. And not only that, the great thing about that is you can make a patient inactive, so the patient drops off your profile, and once they do, you can reactivate the same patient, so you don't lose any data. So we had to go back a year or two and extrapolate some data that we needed for a project we were doing, and we were able to make all our inactive patients active so we can get the information out of it. So it's a great software. If you want to try it out, they have grants where you can try it out, I believe, for like the first 3 or 4 months for free. And like I said, it works in an institution our size, so it would definitely work in a smaller institution. And it's the cost is it's a monthly fee. It's based upon the amount of patients in the system. Again, it's very user-friendly. It's easy to track. So if you're a smaller operation, you could use it. And that was our goal at first. And now that we're so much of a bigger operation, it's still a really good piece of equipment. We still enjoy using the software and have no problems with it.
Thanks. So that's all the questions we have. So Lorna, I'll turn it back over to you.
All right. Well, thank you, Charles and Jennifer, for a really engaging presentation. And again, thank you to all of you as our audience for also participating. The webinar and slides will be available on our website, which again is accc-iclio.org. We should have that up by the end of the week, if not early next week. And also, all registrants will receive an email with the link that will include a PDF of the slides and an archived recording of the webinar presentation. Please also be sure to register for our upcoming webinars. Next week, on January 27th, Catherine Schott will be handling coordination of care for immunotherapy patients. And then on February 4th, Dr. Brian Loy will discuss immuno-oncology biologics, process and issues in setting coverage and policy. So again, thank you so much. I hope everyone have a great rest of the week and stay safe with any impending snow. Thank you.
Thank you.